Okay, good morning, everyone. Welcome to the American Enterprise Institute. We have a terrific program here, a conference this morning with a presentation on a paper that was produced by two authors who you'll hear from shortly, and then followed by a panel that I'll be privileged to moderate with some people who really know their way around this issue, the politics, the policy, and what to look forward to down the road in terms of improvements in American healthcare. To kick us off, I would like to introduce Bob Bixby to come up to the podium. Bob is the Executive Director of the Concord Coalition, a position he's held remarkably, time flies, since 1999. And he's been at the Concord Coalition in various capacities since 1992. For Washington, which is, of course, a revolving door in every direction, it's remarkable to find someone who's been at it at the same organization for so long and so well and so persistently as a consistent voice for fiscal prudence and management and trying to get both parties to reclaim that mantle. Always, it's a never-ending task. So I'll introduce Bob. He'll come up and he'll then describe a little bit about the genesis of this project, the paper that will be discussed here today, and from there we'll go to our panel for some comment. Thank you. Bob.
Thank you, Jim, and thank you for everybody at AEI for hosting us today for this healthcare forum. My job today, as Jim mentioned, is to say a few words laying out the basic facts from the healthcare and the federal budget, as well as explaining a little bit of the context of this paper that we'll hear about shortly. But before I do that, I just want to take a minute to express the Concord Coalition's debt of gratitude to Alice Rivlin, who is a part of this project and co-author of this healthcare paper, and who worked with us on a number of projects over the years, and was one of the first people I talked to. I guess a lot of people in town, when they had some ideas or were thinking about anything fiscally or economically related, would say, well, let me bounce that idea off Alice and see what she thinks. And she was always honest in her assessments, and she was always very enthusiastic about fiscal responsibility. And she made it a lot of us are kind of dour. I mean, sometimes fiscal responsibility people have a reputation for being a little bit sour, and Alice made it fun. And I enjoyed the many trips that we took on our fiscal wake-up tour. Some of them with Joe, as you'll remember, and Doug also joined on some of those. So I think that, for us, we miss Alice very much and very proud that she was able to be part of this project. So the project that this paper is part of is called Towards a Fiscally Responsible Economic Growth Agenda. And the reason that we came up with that is, I think that sometimes there's a tendency to think of fiscal responsibility and economic growth as at odds with each other somehow. And when we look at the long-term outlook, we need to have fiscal responsibility. That's part of an economic growth agenda. But we can't just think about the budget. We need to think about the economy as well. We don't think that you're going to grow your way out of the problem. But the economy is now in a fundamentally different place than it was, say, 25, 20, almost 30 years ago since the Concord Coalition started, when you had the baby boomers in their peak earning years or entering their peak earning years. And now it's very different. We used to warn about what would happen with the economy when the boomers began to retire. Well, here we are in that situation. So, yes, we have a fiscal problem. It's the same depressingly, the same basic problem that we've looked at for 30 years and been, urging members of both parties to make the hard choices. But we also need to look at some fundamental issues having to do with the economy, workforce growth, productivity, that are leading to very slow economic projections, which has a feedback effect into the budget. And so they're kind of interrelated. So the idea is fiscal responsibility and economic growth, and what are some of the issue areas and policies that we should be looking at? Well, I think if you look at fiscal responsibility and economic growth and an agenda towards those goals, no matter how you try to do it, the road leads through healthcare reform, one way or the other. It's the biggest issue for the federal budget, and it has effects on the economy, on state budgets, on private budgets, family budgets, business budgets. And so, hence the idea of a paper on healthcare reform. We also have one on Social Security reform. Doug has written a very good paper on legal immigration. We have one on R&D and worker training. And all of those will be released next week at a Concord Coalition annual Economic Patriots Dinner. So let me just run through a couple of slides looking at the fiscal outlook with healthcare. And I feel a little bit self-conscious doing this in front of 3 former CBO directors, but they're all CBO numbers, so don't blame me if you don't like them. And this is showing our fiscal future. Thank you. Okay, so there's no slide there, and I'm pressing the green button, and I don't know what's happening. Oops. Okay, this is an obligatory slide from the Concord Coalition. If this slide didn't exist, I wouldn't be standing here because there would be no Concord Coalition. There is no matter how you cut it, a fiscally unsustainable future, and if we look at the next slide, I really don't want to look at this one all day, but it is a beautiful slide. Here we are. This is just showing the structural nature of the problem. Revenues are scheduled to grow higher than, spending is scheduled to go higher than revenues on autopilot. That's basically the problem. Up until now, we've tended to spend at about 3% of GDP, and 20.3% of GDP, and tax at about 17.4%. So going forward, that historical pattern is going to break, and we're going to be, instead of running deficits averaging around 3% of GDP, deficits will average more around 4 to 5% of GDP, and that's the unsustainable trend that is behind the earlier slide. Okay, I mentioned the economy. It's not just a budget problem, but the economy is changing. All of the people that do economic projections, whether it's CBO or the Fed, Blue Chip, all show trend growth slowing, where you could usually count on 3 or 2.5 to 3% real growth. Now the projections are about 1.8%, below 2%, and that's a real problem for the budget. And one of the reasons is, one of the questions is, well, why is that happening? Is CBO just suddenly projecting that there's going to be a whole lot more waste, fraud, and abuse, or is there going to be more, are they just being a bunch of gloomy gusses? No, it's actually quite a logical conclusion when you look at 2 underlying trends, which are key to economic growth, productivity and labor force growth. The stunning one there is looking at labor force growth decline from its historical pattern. You look at it going forward, it's going to be real hard to grow at 3% with labor force growth growing so slowly, and productivity growth has more or less been stagnant. So that's given us, some inspiration for what we want to achieve with the economic growth agenda, we have to look at workforce growth and productivity, hence the paper on legal immigration and R&D spending and worker training to try to do something with productivity. Sources of growth are fairly easy to define. When we look at the federal budget, it's mostly health care and Social Security and interest on the debt. Well, you're not going to do anything in interest on the debt if the structural gap between revenue and spending isn't addressed. So the programmatic areas that are most that you really need to look at, again, it's healthcare and Social Security. If you're going to go get a pro-growth economic agenda, it's going to have to look at a fiscally responsible pro-growth economic agenda. It's going to have to look at healthcare. Most of the things that we fight about in the federal budget and that all other category in discretionary spending is actually projected to shrink as a percentage of the economy. So if we want to look at the healthcare programs, why are they growing? Part of it is just because of demographics, more aging baby boomers, people living longer. So if you just put everything on autopilot and didn't add to benefits or assume that healthcare spending would not grow faster than the economy, you would still get an increase in those federal programs. And again, it's not just the federal budget that we're worried about here, but just looking at the federal programs, you would have an increase. But the blue line on top is the more problematic issue, which is so-called excess cost growth, which is the extent to which healthcare spending grows faster per person than the economy. And slowing that rate of growth is the key issue and very much part of this project. What do we spend on the federal budget? Medicare is the dominant federal program in the federal budget, but also Medicaid subsidy, Medicaid, the ACA subsidies, and SCHIP. And again, Medicare is the biggest growing part of the budget. It's, Medicare is going to grow from around total federal health care spending is growing from about 5.3% of GDP to, roughly somewhat, 6.6, I think, percent within 10 years, and around 10% if you look out 30 years. So that's really the key driving factor in the budget. It also is a problem because of the general revenue transfers that have to go into Medicare and Social Security. I think one of the issues that we get on the road quite a bit is isn't Medicare paid for, because we have premiums, we have payroll taxes. The same issue comes up with regard to Social Security. And a lot of people don't realize that both Medicare and Social Security do rely on funds from the general fund with Social Security to pay the bonds in the Social Security Trust Fund. And with Medicare, that's true with Part A, but with Parts B and D, they're designed to be paid for 3/4 of the program with general revenues. So it again, as these healthcare, even with the dedicated revenues, the federal programs, particularly Medicare, does become a growing drain on general revenues, which of course helps drive up the budget deficit. So just in sum, towards a fiscally responsible economic growth agenda, we can't stay on the current track. We have to, if we're going to get the problem under control and get to a more sustainable track, we have to look at federal spending and the mismatch between revenues and spending, but we also have to look at policies that grow the economy. We're going to have to look at increasing labor force growth, increasing productivity and training of the workforce, and the key issues within the federal budget are Social Security solvency and most particularly how to deliver health care costs more efficiently and without sacrificing quality or coverage. So that's a little bit of the setup and the context of the project that it takes place. And now it's my great pleasure to turn the program over to Joe Antos and Loren Adler, who will tell you about the paper and will tell you about all of the ways that this problem can be solved. So I give you Joe Antos and Loren Adler.
Oh. Thanks, Bob. I'm not sure we'll be providing a complete agenda of solutions, but we have some suggestions, of course. So we're here today to discuss a paper that Alice Rivlin and I wrote with the considerable contributions of Loren. It is immodestly titled "A New Vision for Health Reform." Here's the cover. There you go. It's available. It's available on the AEI website. I assume it'll be available on the and Brookings and Concord as well. The idea behind this paper, as well as the other papers sponsored by the Concord Coalition, is to offer bipartisan proposals to slow the growth of federal spending and promote a stronger economy. Now, it was really an honor and a privilege to work with Alice, not just on this paper, but over the years on these kinds of topics. As everyone knows, Alice spent her career working to promote sound budgets while achieving important social goals. Fact is that everyone who will be on the stage today have also had their hands in promoting smarter fiscal policy. However, let's look at the results. When Alice and Bob Reischauer started the Congressional Budget Office in 1975, national debt was $533 billion. Today, it's $22.6 trillion. Well, in 1975, health spending was $153 billion, or 7.9% of GDP. Today, it's $3.5 trillion, or about 18% of GDP. So, we tried. On the other hand, we have to give some credit to past and present elected officials in the Hill and in the White House who, for some reason, didn't always follow our advice. Okay, so that's kind of my introduction. I just want to say that Alice really did fight the good fight, and she will be missed. Okay, let me turn to the paper. Bob's slides gave us a good sense of the fiscal trouble we're in, and also just how important health spending is to this crisis that we're really in. We may not always recognize it as the crisis that it is, but it's as you can see from Bob's slides, if we just let things go as they are right now in terms of rates of growth and so on, we will be in very, very serious trouble down the road. While it is true that national health spending has slowed well below historical rates of growth since probably about 2002, both CBO and CMS actuaries are projecting a return to significantly higher growth for the foreseeable future. We can't say that the honeymoon is over just yet, but it will be over at some point. A viable agenda for growing the American economy must include policies to control the growth of healthcare spending. Otherwise, there's a major risk that much of the economy's future growth will be absorbed by an excessively costly health system without commensurate gains in healthcare. And that's the critical element here. Are we spending our money wisely? Are we getting value for our dollars? And not just federal dollars, but of course, all of the money that we are all putting into healthcare. That, I think, is the critical policy issue. It should be possible to restrain the growth of health spending, and that can be done while ensuring that affordable care is available to all Americans, improving the effectiveness of care and promoting medical progress. A reasonable target, I think, would hold health spending to grow no faster than the economy. That's not the same thing as freezing spending, by the way. People get confused about that. There's still going to be economic growth. So that would leave ample room to support improvements in healthcare without crowding out other policy goals. We're not there, but that is, I think, a goal that we should try to strive for. That does not require pulling the existing system out by its roots and starting all over. Replacing our current mix of private and public financing, markets and regulation with a single-payer system or Medicare for all, I think would be extremely disruptive and costly, both financially and politically. Most Americans they don't say they're in love with their insurance company, but on the other hand, they're reasonably satisfied. They know what they have to deal with their health insurance. And most people are reluctant to give up what they know for what they don't know, especially in this area, especially in health. Of course, everyone would like to pay less. We'd all like to avoid paperwork hassles. And of course, we'd like to spend less time waiting in aptly named waiting rooms. But taking the chance that a massive political change might leave the average American worse off is not a winning political approach for Democrats or for Republicans. Some Republicans also have some ideas that would take us in directions that are somewhat unfamiliar today. So the paper that Alice and I and Loren wrote lay out some policies that frankly are quite familiar. Policy analysts from across the political spectrum have long supported proposals such as limiting tax breaks for employer-sponsored coverage or improving price transparency or finding ways to promote competition among providers. We've made some progress in these areas, but a lot more can be done to make improvements. I would also point out that although we in Washington, and I'm as guilty as anybody on this, often focus on what the government can or should do or maybe should not do, the success of any policy depends on the other actors in the system. States, employers, insurers, health systems, providers, and consumers. We're all in this together one way or another. It's not just the federal government. So controlling costs in this kind of general sense requires a comprehensive approach that addresses the underlying causes of health spending. Basically, the approach that the paper brings forward, again, should be very familiar. We rely on four main tools. First, greatly improving information about prices, quality of care, patient outcomes to promote smarter insurance choices and smarter treatment decisions. Second, shifting away from fee-for-service payment where possible, holding organized provider groups responsible for the cost and quality of the treatment provided to patients. In particular, we have to engage the patients in this. It's not a question of having the federal government or having a health plan do something to a patient. If the patients aren't engaged, it probably isn't going to work too well. People have a tendency to act in their own self-interest. And if the patients aren't personally involved, then it's probably not going to work out. Third, removing barriers to competition among insurers and healthcare providers using the power of competitive markets to drive toward cost-effective healthcare delivery. That's a goal. The healthcare markets are very consolidated. That's a nice word for saying that we have a lot of monopolies or very tight oligopolies in most urban areas. This is a problem that wasn't just invented. It's been developing for decades. So we're not going to turn that around very quickly. But the idea of promoting competition is critical to at least our vision of where we might go. And then finally, and this is another important point, appropriate regulation and direct intervention where markets are demonstrably not workable. You can't solve everything without having an appropriate role for government regulation. The government sets rules that we try to live by. The ACA certainly changed the insurance market in ways that satisfied very important social goals. The government also sets rules with regard to the rest of the operation of the market. The question is, where do you place the marker towards more regulation or towards less regulation? It's not either or. There's a lot that has to be done to work out in specific circumstances where government policy should lie. And with that, Loren, let me turn it over to you.
Sure. Thanks for having me, everyone. Thanks for turning it over, Joe, and the good introduction. It does feel a little bit weird to be up here instead of Alice, but I will fail miserably to try to play her role here. I think to start out, I think jumping off of what Joe said, when we're talking about trying to, I think everyone kind of agrees we have very high prices in this country and very high health spending. Bob's slide deck obviously showed health spending in this country tends to be very high, has grown quite rapidly over the past decades, and tends to be sort of abnormally high compared to the rest of the world. I think it's sort of useful to take a step back and just sort of break that out to some degree. So, our health spending at its simplest level is the prices we pay for things and then the quantity of the services that we're using. It does seem that our sort of prices are more the outlier here, and that's sort of where I will focus a bit. And it seems to be the thing that has sort of grown the most rapidly in these past decades. We now, one of the great things of sort of the proliferation of data in healthcare is we now have a much better picture of really seeing that hospital prices in particular have grown quite rapidly in recent years. Not just hospitals, it is other providers and prescription drugs and everything as well. But we now are paying for hospitals are the average rates that insurers are paying are something like twice the Medicare rates. I think there's sort of some question of like what are the prices that we want to be spending for healthcare to set the table here, and I don't think that's always perfectly clear. As sort of Bob was mostly alluding to, there are a lot of downsides to spending more money than you want to, and sort of the right prices are, how much do you need to spend to get hospitals to efficiently deliver an efficient hospital to deliver quality care. If you are spending too much on that, you are taking resources away from other things. Consumers are spending a lot of money here. You are incenting inefficient delivery of care, and particularly getting people to lowering access to care effectively. The more expensive things are, the more expensive insurance is, less people have coverage. So they have a lot of problems there. I mean, obviously on the downside, with too low prices, you can run into access to care or quality of care issues as well. I think most of what this paper tries to do is kind of lay out, sort of the framework for thinking about how do you get at, lowering prices and getting the quantity, mostly in a, sort of using regulation, heavy-handed regulation, kind of only where it's, I think more where the market failure is very clear, trying to kind of rely on the competitive forces as much as possible. I think to that end, I like to break it into a few sort of subcategories here. I think one of the first one is, I think we often call sort of stop digging the hole deeper here. There are a lot of sort of self-inflicted wounds in healthcare that policymakers have kind of made the problem work, either incentivized consolidation. There are a lot of state policies, for instance, like certificate of need laws that make it harder for for new competition to enter these markets. We explicitly pay more money to do the exact same services if it's done in a hospital rather than a freestanding physician office. There's a lot of those things that are very much self-inflicted wounds here. And there's a lot of the state laws, like any willing provider laws, freedom of choice laws, that basically sort of undermine the way sort of insurers, we've kind of dictated to insurers to help control costs here, is that they can have selective contracting and they can create networks that are supposed to be a way to save money, but that can't work when some of these laws sort of force you to have everyone in network. For instance, I think often this gets talked about in a different bucket, but I really think of the tax exclusion for employer-sponsored health insurance in this manner as well. It is very similarly a policy that incentivizes higher spending on healthcare. We are for every dollar that employers spend on healthcare, we are giving a 35% or so tax break on that dollar, and it's uniform. So the tax break doesn't matter how much for the 50,000th dollar. You're still getting that same sort of benefit In that same way, you're right, you're just reducing the incentive that employers have to care about healthcare costs in a way that is unnecessary. I think of those as kind of some of the main, as sort of the easiest things in some way to do, because they are, well, easiest policy-wise, because they're self-inflicted, but to actually, they're all there for a reason. They're all there for a reason that they're politically popular. So not actually easy from a political sense. I don't want to claim that. Not any easier necessarily, but right. I think. I mean, Joe made the point. Right. We now have very consolidated hospital markets across the country. I think it is very fine to sort of say that that our sort of agencies like the FTC should be applying greater scrutiny to hospital mergers, and I think in recent years they have, especially to new mergers. The problem is, markets are already pretty consolidated. It's hard to know exactly how much that can do unless you're willing to go to bigger steps of, until you're like willing to talk big things like breaking up hospitals, which I don't think is really in the cards. It's hard to really imagine how you're going to get a ton of competition in those markets, but there certainly are. You should be at least trying to not make the problem worse. I think is part of on that. I think the flip side is right. So now we have kind of there's the demand side of this as well. So right there are. I think we've in the past decade or so we've done a fair amount of experimentation with sort of putting the patient's skin in the game as being the phrase du jour, or was, I guess, the common phrase. With higher deductible plans. I think we've seen sort of limited effectiveness of most of those approaches in terms of actually reducing sort of reducing the care that you want to reduce. It seems that they're a little bit haphazard in the sort of care that they're reducing. However, I do think in this sort of experimentation, we have seen some more narrow elements where with price transparency, the degrees that we're having, we have seen things like reference pricing where you basically tell that your enrollee or your employee, you have a certain amount of money to spend for a hip replacement, and you can, and we've made sure there's 20 providers who will do this, or whatever, 5 providers who will do this, who we think are good quality, but we want you to use them. If you're going to use the crazy expensive person down the street, you're going to have to front that.
You mean the highly professional person down the street?
Yes, sorry. Yes, that is the overarching thing here is, right, prices in theory are supposed to reflect quality. That seems to not always be the case in healthcare, to put it kindly. I mean, it's not, like to some degree there is, but it's a very minimal correlation here. And then on I think, some of these other things were kind of supply side as well, but on this sort of more, the sort of formal supply side of this equation, we also have a fair amount of restrictions on just who can practice medicine in this country and on becoming a doctor, and also on just sort of the hurdles that it takes for foreigners to come into this country to be doctors. I think something like half of our primary care workforce at this point is foreign-born physicians. So we have a fair amount of this already for the lower paid types of specialties in this country. I think there's sort of a lot more we can do to sort of increase competition. And most of this comes to scope of practice as well, where we have a lot of procedures where a nurse practitioner or a PA could do a lot of your sort of primary care or a lot of your kind of simple tests and things like that, and take some of and basically provide more competition into the provider markets. And that's really kind of that's the only way that's sort of the way you can help reduce prices here a little bit. As Joe said, I do think there are certain areas that, I think on these fronts, there's at least some hope that infusing more competition can help reduce prices. I think there are a few markets in this country where that really is sort of hard to ever imagine it working. I think we mostly reference emergency care in this paper as sort of a market where it's really hard to kind of imagine is sort of having sort of true market forces there, is one where we kind of talk about actually.
We're living this right now.
Yes, this
with
is
surprise billing.
Yes, this is my my niche issue at the moment. But yeah, so the surprise billing debate in Congress right now is all about emergency care and the sort of providers that patients don't choose. So your anesthesiologists as well, where I think it is very hard to have a traditional market because they can kind of go out of network willy-nilly. It's sort of even when the hospital they work at is in network and charge you basically whatever amount of money they want. I think that can be pretty fixed by just making it so that they they effectively have to be in network if the hospital is in network. Those sorts of regulations. So it's not explicitly a price regulation, but effectively is, using a stronger regulatory hand here. I think just the last thing, I sort of left out prescription drugs, which are, 10-20% of our spending at this point. I think in this paper we mostly focus initially on, obviously I think this paper largely tries to see like how much can you do without kind of going with the heavy-handed regulation. I think there are at least a lot of ways you can improve the system. Again, this is a debate going on in Congress right now. Particularly in terms of, so there's a lot of talk of redesigning the benefit package that Part D, the Medicare prescription drug plans have. So there are a number of things in that. For instance, reforming the reinsurance portion, which effectively is just sort of the government pays almost all of the costs of the really expensive drugs, which weakens incentives to be negotiating, right? So we've put these insurers in charge of kind of negotiating prices, but we haven't always given them the tools to actually do that. And similarly, Part D, we have, there's just a handful of these rules like protected classes where you have to have all drugs in certain classes, in your formulary for your plan. For those sorts of things, right, there's no way they can really use competition. That also applies to drugs that just don't have any competitors. That one doesn't have sort of the natural fixes that these do. But there are certainly plenty of things. And I do think Congress and the Part D benefit redesign is looking at a lot of these ways to at least give Part D plans more tools to be negotiating drug prices. Yeah. I'm going to mention the quantity side here I think is a little bit tougher, and I think most of the experimentation is underway right now. We've been doing this sort of large experiment with accountable care organizations and bundled payments. And all of this work going on, mostly administratively. I think we've seen modest, not huge, but modest lowering of costs from these. I think it's hard to imagine you're having, enormous savings from these policies, in part because it's not as clear that our quantity of services are like that that we're over-consuming care in the same way. To the extent that you're actually improving the quality of care, though, which I think that's sort of what the evidence shows so far, that is a valuable thing, regardless of kind of how much you're saving here, which goes back to the kind of fundamental premise of the paper, right? I think there is part of the value of reforming healthcare here is to, obviously, ideally to incentivize quality care, to help sort of remove unnecessary resources that are going towards healthcare that could be going to other sectors of the economy. But we want to be doing this in a way that actually is improving healthcare as well. And I think I'll.
Okay, good. Yeah. So one of the you made an awful lot of points. It's hard to pick out one that from earlier on, but I'll attempt to do that. And this has to do with this idea of consumers shopping. And Loren made a reference to the idea of reference pricing. So I thought we ought to talk about that a little bit. There's a lot of skepticism generally that whether consumers can really shop. But there are a couple of reasons why that skepticism is justified, and it has to do with what are the circumstances that consumers face right now. Well, first of all, consumers, I'm a consumer, I'll speak for myself. I don't have the information I need to know what my options are in terms of, what the therapeutic options are, which provider I could go to, what the prices will be, and by the way, what price is that I care about? I'm just like everybody else. I don't care what the system has to pay. I care what comes out of my pocket, even though, because I'm dumb, I don't understand that I'm also paying into the system. But I'd like to ignore that.
It's diffused over 100 million people.
Yeah, exactly. It doesn't have anything to do with me, even though it's a huge amount taken out of my salary. But certainly people do respond if they in other markets to the price they have to pay out of pocket. The reason it doesn't happen much in healthcare is we don't know what we're choosing. We're not getting good advice from our physicians, who also don't know what the options are. We don't have good information about the quality of services that might be available. A lot of advice that we get from our doctors is based on what's convenient, either for the patient, for the physician, or more disturbingly, for the health system that the physician is associated with. So I might need an MRI. I could go to the hospital. That's the most expensive place to get an MRI. I could go to a freestanding imaging center. That's far more cost effective. But if my doctor has signed a contract with a health system that says, send everybody here, he's going to send me there. And I probably will not have much of a basis for saying I want to go somewhere else. And why? Well, because I don't know what it's going to cost me out of pocket. And furthermore, it will be a tiny fraction of what it is of the cost of the system. So we don't have the financial incentives, we don't have the information, we don't have the guidance from our physicians, who we go to primarily for information, not necessarily for treatment. That could all change over time, but a lot of it goes back to changing the subsidies for the insurance market, improving information, and getting the doctor to have more information, him or herself, about all of the options, including the financial considerations that we don't have right now.
Yeah, no. It's worth noting, right? There is evidence that when physicians have the costs and are actually incentivized to care about the cost, then they actually are kind of making more cost-effective choices. That there's better, like that we do have sort of firmer evidence on it.
Yeah, I think doctors want to do right by their patients.
Yeah.
And they could do more right by their patients if they had better information about what we are faced with in terms of the financial consequences. Let's see, should we see if anybody wants to interrogate us? We have a little time for a question, if anybody. Yes, please. Oh, I think there's a microphone. Could you,
I think it's coming, yeah.
say who you are and give us a question.
If we can get it working.
It's working perfectly.
Technology's not there.
Hi, my name is Justine Summers. I'm a resident anesthesiologist. So just very quickly, the whole characterization about doctors just dropping out of network willy-nilly. I've talked to a lot of providers, and that's not really what we went to 4 years of medical school and then residency and then everything else to do. I'm actually interested in, lately, with the surprise medical billing conversation, there's been a lot of conversation surrounding private equity and their involvement in the marketplace. And I was wondering if you think that if that's one of those places where government regulation is necessary, possibly, especially we're hearing that these private equity firms rely on high surprise medical bills to pay down the big debt that they accrued to gain these medical companies. Like Envision paid, I think, $9 billion, or was bought for $9 billion by its, I think, KKR. So I was just wondering, because doctors, I find that we're kind of caught in the middle. We don't have a lot of choice about where we practice. We don't have a lot of choice about being a network, honestly, because especially for anesthesiologists, we have to be a network often to work in the hospitals. Insurance companies know this, and so they give us a take it or leave it price. So we end up rolling into private equity owned Envision in order to even try to compete or try to come to the table with insurance companies. It's all very complicated, but so I was wondering, there's a lot of talk right now with ENC trying to investigate private equity, and I wonder what your guys' take on that is.
I guess I can take that one.
Yeah, please do.
Sorry for the characterization. I honestly was just sort of trying to scan through that part quickly as it was sort of non-central to the paper. But yes. But certainly that was one of the areas I think we were saying was ripe for regulation. I agree that most physicians are not not explicitly using the leverage of sort of threatening to go out of network in order to get paid more explicitly. But there are plenty of these companies like Sheridan or probably Mednax as well, honestly. I'm just thinking in anesthesia. But so Mednax is a public company, right? I also think like the private equity thing is a little bit loose here. Envision and Team Health were public companies 2 years ago. But I think there's no real way. Right now, you can threaten to go out of network, make a lot of money doing that way, and then offer to pay physicians who come work for you more money. Physicians who work for these companies typically don't even know what the billing practices are, but they know that the salary being offered is higher than they would have made elsewhere. I think the only way to get rid of that is effectively to make it illegal for providers that patients don't choose, to make it illegal to balance bill patients in some form. I think that is, to me, is actually the main portion of this. I think you can kind of craft these rules or regulations in different ways, but making it illegal to make that threat is, I think, the critical part here. And I think at that point, you've sort of returned it to a more normal market negotiation. I think for your kind of ancillary type physicians, like your anesthesiologists, radiologists, and pathologists, I think it's very easy to imagine there actually being a market, just because hospitals actually need those physicians to work there. It's not the same thing, but they need a nurse in the same way, right? A nurse gets paid money because the hospital needs a nurse and a nurse needs a hospital. So I do think there is a solution there.
So let me just make a general statement about this, that with surprise billing, the economically weakest entity, namely the patient, is the person who is kind of caught in the middle. It's not the doctors. It's not the hospitals. It's not the companies that organize this. By the way, those companies are in this because there is a financial opportunity.
Yeah.
So if you change the rules, then that changes the incentive. And you might not get what you want, but you will get a change. But the fact is that patients are in the worst position to bargain with anybody else, and it is a question of contracts. So what should the contracts say, and who are the contracts with? As I have to say that healthcare is really quite an interesting industry because the patient can be put unconscious, and then his pocket can be picked. And that's not a statement about anesthesiologists. That's just a statement about the way healthcare is financed. Fact is that when a patient goes into a hospital, you sign a bunch of papers that you haven't read and that you wouldn't understand if you read them. And so the patient has no leverage whatsoever. It's up to the big economic entities to do their job on behalf of somebody who's supposed to be a customer. So we should stop calling us patients. We should start calling us customers.
Sorry, I don't know.
Thanks. Mike Miller, I'm a health policy physician. And Joe, you had a great description of the role and balance between market competition and government regulation. Mostly you guys have talked about that in sort of site of service or types of service, types of providers. Can you talk a little bit about, the rural issue where competition is really a challenge? Partly, I think, because that's going to bleeds over significantly into politics, particularly coming up the next year or a few years. Thanks.
Well, certainly for the next year and a quarter, there will be people visiting semi-rural areas looking for votes. I don't think that has anything to do with healthcare. We have a problem there, but part of the solution, there's no easy solution here, but part of the solution is to take advantage of the technological advances that the healthcare system has made and that modern electronics makes possible. So telemedicine, for example, makes an awful lot of sense especially in the most remote areas. Now, that doesn't work unless there's somebody in that local community, that local rural community, who can kind of shepherd things around. It doesn't have to be a doctor. It doesn't have to be a nurse. In some areas that are handled by the Indian Health Service, for example, they recruit. Typically, it's going to be like a middle-aged lady, somebody who's probably a mother, so she's seen some medical things personally, and who is not afraid to take that responsibility and to learn some things, and provides real benefit to that extremely rural community. Well, you don't have to go that far, but the idea of having somebody in the rural community who can be the interface, along with some reasonable communication between the doctors who don't want to live in that rural community and the patients who are living in that community. And they tend to be, by the way, older patients. They tend not to be the young people. So yeah, there are things we could do if we take advantage of some things that are actually technologically possible today. But we're not going to solve every problem. And frankly, the idea of having a fully staffed hospital in every county in this country is wrong. You can't do it. It's physically and financially impossible, and you can't get the doctors to live there anyway. So you got to find a better way of delivering services in a way that doesn't require so much bricks and mortar, and recognizes that, in fact, transportation is now a little bit better than it used to be 100 years ago. So we could probably deal with a lot of these problems through moving the patient or moving the provider, but not permanently having the care delivered in that community. Maybe we have time for one more. We have to get to the other panel.
You want to pick?
I have no idea. How about this lady? It better be a good one.
Hi, Christiana Alexander from Blue Cross Blue Shield Association. You've referenced this earlier, and I've heard it in a lot of these meetings, but there's this idea of putting more physician responsibility and educating patients about the costs. I'm wondering what that kind of policy would look like, given that, like she said earlier, is you're going to school for many years. It's not business school, it's medical school. And most patient appointments are 20 minutes, and the waiting room is a consequence of already going over that 20-minute patient consultation. So what would that look like to put more responsibility on physician education? Or education of the patient.
Okay, so don't think about the way it is today. Think about the way it could be in the future. Because obviously, right now, no physician has very good information that is specific to any given patient about the out-of-pocket costs, for example. We're a ways from that. But it's going to require some effort on the part of insurance companies to coordinate better with the entire rest of the system to provide that information in a way that's digestible. It doesn't require the physician to talk it over with the patient, but it probably requires somebody to hand a piece of paper to the patient and be prepared to answer some explanation about what's going on there. It might be the office staff. I'm thinking about the case of diabetics and insulin. One of the issues is, could a diabetic switch to a cheaper form of insulin? Many people who work in this area have told me, I don't know this personally, but have told me, well, there's a possibility of switching people to a cheaper product, but patients and doctors are reluctant to do that because it requires some education. The doctor doesn't have time. As you said, the doctor doesn't have time. But perhaps someone else with medical training, less than a doctor, would have the time to work the patient through what the pluses and minuses are of making a switch, and then make an informed decision. So there's nothing easy about this. What I'm saying is look to the future. Don't look to the past. We're living in the past right now. Thanks. Let's adjourn for the panel.
Okay.
Button on, there you go.
I hope I got that
I'll
right.
behave.
I think it's right.
It's an interesting question. I'm a diabetic.
We'll go ahead and start with our panel discussion. That was an excellent discussion about the paper that was produced by Joe and Lauren, and we thank the Concord Coalition for sponsoring the paper and getting us started this morning. My name is Jim Capretta. I'm a resident fellow here at AEI, and I'm glad to be a part of this program. My job today is just to moderate this panel of very distinguished speakers. We're very, very grateful to have this. I think Brett Baer calls his group every night on Fox News the All-Star Panel. I think we have our own All-Star Panel here this morning. Really people who have been around this issue quite a long time, not to date us all, but people with a great deal of depth of experience, both on the policy side and understanding how that interfaces, unfortunately, sometimes with the political side and how to navigate both parts of our American system here. I'll introduce each of them, and then we're going to invite them to give a few minutes to kind of set the stage, and then we're going to reserve a lot of our time just for us to have a conversation about it. I'll ask questions and try to be as provocative as possible to get them started. So we'll be led off this morning by, I'll introduce all of them right now, but our first speaker will be Douglas Holtz-Eakin, who is the founder of the American Action Forum. He also served from 2001 to 2002 as chief economist at the President's Council of Economic Advisors, just prior to assuming the directorship of the Congressional Budget Office, where he served from 2003 to 2005. In that capacity and capacities at the American Action Forum, he is deeply enmeshed in these debates around prescription drug pricing, insurance coverage, regulation, and markets. So he'll be an excellent person to kick us off. He'll be followed by Sheila Burke, who is an adjunct lecturer in the public policy program at the Harvard Kennedy School. She served as executive dean of that school from 1996 to 2000. Previously, she had a very long tenure on Capitol Hill, serving as deputy staff director at the Senate Finance Committee, and then as chief of staff to Senate Majority Leader Bob Dole, where she also served on his campaign for the presidency. After Sheila, we'll have another former aide to a staff director, to a Senate Majority Leader. We'll have Dan Crippen. Dan was the executive director of the National Governors Association from 2011 to 2015. He worked with the governors to identify and prioritize many different questions that the governors faced, but certainly healthcare was always near the top of the list. Earlier in his career, from 1999 to 2002, he also served as a director of the Congressional Budget Office, and he came to Washington working for former Senate Majority Leader Howard Baker, and he also served under Majority Leader Baker in the White House for President Ronald Reagan. And then he'll be followed by Bob Reischauer, who is a Distinguished Institute Fellow and President Emeritus of the Urban Institute, which he led from 2000 to 2012. He also served as a director of the Congressional Budget Office I know you're sensing a pattern here. From 1989 to 1995, as Joe alluded to, he also helped set up the institution, the Congressional Budget Office, with Alice Rivlin in 1975, serving as deputy director of the CBO. So I really can't think of a more distinguished group to help us talk about how we're going to improve our health system than this one. And so, Doug, why don't you kick us off?
Well, thanks, Jim. And I want to begin by thanking the Concord Coalition for this broader effort on policies for better economic growth, AEI, obviously, for sponsoring this event, and thank Joe, Alice, and Loren for a tremendous paper to discuss. It is odd to be discussing a paper by Alice Rivlin. She's deeply missed. There's an old saying that the best sermons are not spoken but lived, and I think Alice fits that. She was a fantastic person, a great colleague, but an inspiration to those who didn't ever really get a chance to meet her, and she'll be missed for a long time. I want to start just by emphasizing how important I think it is to focus on growth, and why I like this project so much. From the end of World War II to about 2007, the U.S. economy grew rapidly enough on average that GDP per person, income per capita, a crude measure of the standard of living, doubled roughly every 35 years. So in one working career, the standard of living would double, and that was the route for many people to get their access to the American dream. That certainly was my parents' experience, my father coming out of the Navy, entering into that economy, and allowing people to send kids to college, buy homes, vacations, whatever they really wanted to aspire to. Given the projections for the demography and for the economy, the expectation now is that the standard of living will double roughly every 75 years. And so there's a palpable sense of access to the American dream disappearing over the horizon. And I think that's an important part of what's going on in the United States politically as well. In that key election year, 2016, the real income of those households that worked full-time for the full year rose by exactly 0. And so policies that keep an eye on the capacity to grow more rapidly and provide better resources for our private sector desires and our public sector needs are policies we need to pursue relentlessly. And I think it's important to talk about that in the area of health because for some reason we sort of have this idea that it's off limits. It's different. Health is somehow special and immune from market forces, or even worse, shouldn't be allowed to let market forces influence it. It's now nearly a fifth of the economy. If we cordon off a fifth of the economy from the requirement that we have adequate productivity growth, we're going to make the job that we have much, much harder. And so I like the fact that they wrote such a great paper that really took a look at where can you successfully inject market forces, produce better incentives for productivity and growth, and where realistically can you not? And one of the nice things about the paper is it's quite balanced. It's not some pie in the sky reform everything under the sun. It's let's go through piece by piece and see where we can use market forces to get things to perform better. And they do some things that you would expect in that regard. We talk about price transparency and the capacity to make judgments about value. What does this cost? What will I get for it? And it's something that is harder to do in health than anywhere else in the economy. And they sort of go through the typical menu of things that we can do for individuals and turn them into better shoppers. But I like the fact they recognize that can't be the entire answer. I really don't think that's a realistic solution to what we see going on out there. And to think about what can we do for incentives on insurers who we have, in fact, largely put in charge of controlling costs? How can we improve their incentives? To come back to some things that have, in recent years, gotten kind of a bad name, like ACOs. The idea of an ACO, an accountable care organization, is a perfectly sensible idea. The problem in the actual implementation of the ACOs we saw in the real world is people didn't join them. They didn't raise their hand and say, hi, I would like to have my care managed. Would you please make very sensible decisions about the least cost way to get me quality outcomes? They were assigned to them. And if you're assigned to something unwillingly, as Joe mentioned, you pursue your self-interest, which is like, let's just ignore this ACO, let's complain about it, let's make sure it doesn't work. There's a place for endogenously incentivized ACOs and other kinds of organizations that will in fact do the management of care that is going to be necessary. And so I really like that a lot. The only thing I'd criticize in the paper, I mean, it's a scary thought to do that, is I thought it was light on reforms to federal programs. We know that Medicare is the big payer in the economy, and Medicare has for decades driven care on a fee-for-service basis and produced a lot of the problems that we have in our system. And I think if you're going to, there are no magic bullets and levers in this operation, but if you're going to sort of pick one place to really sort of make a big difference in the delivery system, the cost of care and the quality outcomes, it would be to focus on the big programs, Medicare in particular, Medicaid as well. That's an important part of reforming and injecting some better market forces into this. But on the whole, I highly recommend reading the paper, and I applaud the focus of the paper and the project in general.
Sheila.
Thank you. My thanks as well to the coalition and to Brookings and to AEI for holding the discussion. I have to tell you, it's a little daunting sitting with 3 former CBO directors, all of whom at one point or another gave me numbers that were either good news or bad news in the work that I was doing.
Who gave you good news?
That's a good question. I think we did. But the point is, they are all remarkable public servants and did just a remarkable job. And certainly from the standpoint of a staff person, really made our lives so much easier when we literally had our own source, a congressional budget office, to provide us numbers. Just made a big difference, which brings me to Alice. And like all of us on the stage, we've all had the opportunity to work with her. I did most recently at the Bipartisan Policy Center, and she was just remarkable. Often demanding, very inquisitive, but always willing to take on the tough calls and the tough choices and the tough issues. So we, in fact, will miss her tremendously. I have been asked, interestingly enough, and my compliments to Joe and to Loren for the quality of the work. Like Doug, I found it tremendously interesting and useful, and gave us an opportunity to look at a variety of issues. But I've been asked to talk about what's doable as the staff person. And so I will spend just a few moments.
It's Dan's turn now?
It's now Dan's, and I'll turn it over to Dan, who also spent enough time on the Hill to experience this. But I'll talk a little bit about what I think is doable and what some of the issues I think are. I think there's no dispute that the spending issues are, in fact, ones that are driving us and driving the discussions for many of the reasons that Doug suggests. It is both the percentage of GDP that's going towards healthcare. It is the solvency questions around Medicare. It is the lack of investment and the return on that investment. I mean, we keep hearing these statistical comparisons between us and other developed countries, and the fact that we spend so much and get so little in return in terms of the quality. It's the impact on wages. It's the impact on employers, on jobs. And it is, in fact, the impact on households in terms of what they have, the resources they have, and what it is that they need. So all of those things. I know Dan's going to touch on this, but I would also underscore this is not just a federal issue. It has an enormous impact on states. And states that are now experiencing Medicaid budgets that are literally the second largest thing in their budgets after education. And it is draining away, as it does at the federal level, at the state level, their opportunities to do other kinds of things. So as we look at solutions and we look at what's been suggested in the paper, it is really both a federal and a state play. And questions around state innovation, state flexibility, the ability of the states to engage in these conversations, I think has to be a part of what it is that we talk about. So both on the demand side issues that were raised and the suggestions that were made, transparency, reference pricing, moving away from fee-for-service, to Doug's point, removing the barriers to competition, regulation is needed. All of those are things that ought to be, in fact, in play. Interestingly enough, as is pointed out at the end of the paper, this builds on the existing system. This is not a radical restructuring of the entire system. Rather, it builds on the strengths and potentially addresses some of the weaknesses with the existing system. One of the fundamental questions here is, are people prepared to do a radical reform? Are, in fact, we going to be building on sort of what we know today to be the existing system? Which has been an issue that we have fought over for years. and that is, to what extent do we do incremental change, which at one point was viewed as sort of a negative, incremental, or do we do wholesale reform? And that's at the heart of some of these discussions as we look forward. But all of those suggestions, all of those tools, in fact, also have to look at what it is the public basically views as being the problem. We're going to, and I'll touch briefly on what I think the members are willing to talk about, but at some point, the last point that was made was the importance of the public in these decisions, the role of the public, the role of transparency, the role of decision making. So I turned to a poll that was done at Harvard in March, and the poll asked the reasons for the nation's healthcare costs and high costs, and it asked the public these questions. And they identified essentially, one, that 54% of the population thinks healthcare costs are in fact a problem. So we know that there is a reason, and hopefully that the current debate will in fact continue that conversation. And it gave us the top 5 reasons that the public think cause healthcare costs to be a problem. The first was drug companies and the prices charged by drug companies. The second was the prices charged by insurance companies. The third was the prices charged by hospitals. The fourth was the prices charged by doctors and other health professionals. And the fifth was the actions taken by the federal government that raise healthcare prices. And those were the compelling reasons that the public thought, in fact, we had a problem with healthcare costs. Somewhere down around 17, it's patients not taking responsibility for their choices regarding low-cost care, patients seeking health care that they often do not need. This would suggest to me that the public views all of us, that is Washington, largely, some state, as being the reason. That is, that it's someone applying the prices to them rather than any role that they might play. So as we look at the solutions and we look at what is doable, we cannot forget what the public's perception is. So when it comes to issues like facilitating choices, providing transparency, giving them options to opt in rather than simply be assigned to other mechanisms, we have to keep in mind what the public views as their ability to make these decisions and the tools that they will need in order to make these decisions, which has to influence what we do. So what's doable in the near term? I should note, again, that the paper builds on the existing system. So much of what is, in fact, currently being debated is, in fact, within play and has been noted. Surprise medical bills. There seems to be a consensus around that being a problem, but we are falling short of a solution that we can all agree on. We have bills in both the House and Senate. We have what we think are the elements of a compromise in terms of whether it's essentially being a network or not, whether it's negotiating what the solution will be, but there is at least the opportunity there for perhaps a consensus to be built. Drug prices. Again, much in the newspapers every day, clearly an issue that the public has raised. There are a variety of proposals out there. There is a principal understanding that drug prices, in fact, are a problem, but critical difference in terms of the solution. Whether, in fact, the government ought to be in the business of negotiating prices, in fact, whether we use reference prices in terms of other developed nations. So again, the principle that is we ought to do something about drug prices, but the mechanisms to be employed, there remain tremendous differences. Pre-existing condition protections. Clearly, as we look at the ACA, look at all the pushback to the ACA over the last 10 years, the one thing that people don't want to lose is that protection for pre-existing conditions. So there's a general agreement that's critical, but a disagreement as to how one achieves that, whether one can achieve it only through essentially a federal solution or not, and what the role of the private sector would be. A movement away from fee-for-service, to Doug's point. I think everyone agrees that the fundamental payment system in the Medicare program has led to, in fact, the incentive to do more to get more. That the fee-for-service system has left little incentive for people to essentially be alert. Whether it's ACOs, the changes we've seen in Medicare Advantage, we've got more than 30% of the population now in a Medicare Advantage plan and seemingly quite satisfied. We've seen positive results by moving to a capitated kind of system where there is risk bearing that takes place. But clearly an agreement on the movement away from fee-for-service. The question is how quickly and what you replace it with, and how quickly it moves into all of the systems that we know today. How many are prepared to essentially do that? state innovation, which I think Dan will talk about, the extent to we give the states flexibility, particularly around their Medicaid program. The risks of doing that, some of the issues that have arisen with respect to whether it's work requirements or other flexibility giving the states in terms of benefits and structures. We've seen the uptick in the uninsured that we heard about only a couple of weeks ago was largely a result of an increase in essentially the dropout of Medicaid. We saw a 1.9% increase in terms of an increase in uninsured that is directly a result of the Medicaid program. Medicare enrollment's going up, private sector enrollment relatively stable, but in fact the increase has been as a result of Medicaid. So questions in the balance, how much flexibility in what areas and what the result will be in terms of what's taking place in the states. And of course there's always the expansion question that comes back into play, those states that have chosen not to do so, or what the rules ought to be that allow them to do so. The development of generic drugs, lots of conversation in the drug pricing issues, lots of interest in incentivizing essentially generic drug production. But again, the question becomes how and with what tools, what the role of the FDA might play. And this underlying question of competition. A number of things that were raised in the paper, but have come about in terms of how does one increase competition? How does one relook at consolidation? And to what extent consolidation has led to higher prices, and whether the federal government ought to get involved essentially in looking at what that consolidation looks like, whether it's in hospital systems, whether it's in physician practices, in a wide array of activities. So a balance in terms of what the regulatory changes ought to be and what the federal government's role is in terms of solving that problem. At the end of the day, this question of the role of the federal government, the role of the private sector, is really at the heart of a lot of the disagreements. Again, these are all topics where they have been raised. There seems to be general agreement, both from the public's idea of what a problem is, as well as the recognition by the states and the federal government. The question is, what's the balance? So let me leave it there and hand it over to Dan.
Thank you. I can't, of course, join my colleagues in admiration and appreciation for all that Alice has done, not only in this topic, of course, in general fiscal, but the many roles she's played with good grace and great wisdom, and we will miss her. My colleague here, Bob Reischauer, knows her better than anybody in the room and could tell you lots of good stories. Thanks also, of course, to AEI, Brookings, and the Concord Coalition for keeping this conversation going. We do see some of it on the Hill. Sometimes it's hard to know exactly what they're talking about, but we do see at least some considerations of healthcare. Let me start by saying I had a professor once who often said, in my younger and thinner days, I think I finally reached that status. I say that in part because many of you were born before the concern about healthcare spending, especially federal spending, started. Probably Bob has written papers about it. We all at CBO worried about it. It's not a new phenomenon. Entitlements we knew were going to grow faster than tax revenue, certainly faster than appropriations in general. So we've known this for a long time, and we've all been worried about it. Which reminds me of something that Herb Stein said when he worked at AEI, which was, if this can't go on forever, it won't. However, Herb left us before he told us when. So we have been, and certainly I have been, talking about this can't go on forever for a long time, but it continues to go on. So we don't know what the precipitating event is. We all believe that it's unsustainable. We all believe that it's uneconomical, but we have to do something about it. We've just never had the fortitude to do it. I want to talk about two issues quickly. I'll do neither justice in certainly this time frame. One is chronic disease, the role it plays in all that we're doing, just as a backstop. And then second, of course, as Sheila and others have mentioned, some of the things states can do and are doing. First, as most of you know, chronic disease is 75% of our healthcare spend, treatment of chronic disease. And so any changes we talk about, whether it's in this great paper or on the Hill, it has to be in the background of what does it do to change this spending on chronic disease and the recipients of the folks who have chronic disease. By the way, Sheila reminded us that they're working on pre-existing condition. Chronic disease means pre-existing condition. So 75% of our healthcare spend, folks have pre-existing conditions. So we're making a guarantee for paying for them, or at least covering them one way or another. Most of these folks that have multiple chronic conditions, not just one, multiple physicians, multiple pharmacy, multiple virtually everything, and without much coordination of care. And we're hoping, as Sheila said, ACOs and others, and Doug said, will help coordinate that care. But certainly in the current construct, ACOs aren't doing much to at least change the payment for care. We're hoping that managed care, whether it's inside Medicare or other places, can help coordinate care. While we see a little of that, if you look at internally, the managed care companies are still largely practicing fee-for-service, paying for services within their cap, which means lower prices probably, and maybe some control of quantity, but certainly not doing much on coordination. We had hoped that health information and all the money we spent on it would help coordinate care. We've gotten here without much interoperability, so there are silos, if we say, of information, different people holding it, and nobody really being able to do a lot of analytics on it. So all of the hopes we've had about chronic care and multiple chronic care delivery coordination have not really been borne out yet, certainly in Medicare and in Medicaid, which is largely now managed care. But the per capita spending, the caps on managed care are tending to go up almost as much as everything else. So we haven't really stemmed the increase, which is part of the real importance that Joe and others talked about up here. So much for chronic care. States have a great effect on health care and often don't recognize it and certainly don't do much about it. I would argue, and this is only a slight overstatement, that states control much of the supply of health care, whether it's the workforce, as Sheila knows better than I, the number of nurses being trained, the number of physicians being trained, the curricula that they use, whether it's, if you will, kind of modern or not, is a great effect. Others mentioned certificate of need as one prohibition on increasing supply. And the number of hospital beds, nursing home beds, all of those are often controlled. And as others have mentioned, regulation, which affect the supply, like scope of practice. We don't let nurses and others practice at the top of the scope of practice, top of their license. And all of those restrictions, of course, are often maintained in part because of the current practitioners not wanting this change. And so we have a great deal of effect on workforce and supply, but we also, of course, as others have mentioned, regulation. Often health care insurance is regulated at the state level. We've had federal fights over this for a long, long time on whether or not it be federal, state, and what part of it. We also have, of course, the states being primary purchasers of health care. I'll get to Medicaid a little more in a moment, but they pay for their own employees, their own retirees, help school systems in some cases, and of course Medicaid. So if they wanted to exercise that purchase power, they certainly would have a lot of effect on how we practice medicine, what data is collected, who gets it, all those kinds of things, whether behavioral health is implemented, how that's done, because there's a data issue. And so the regulation that states have, and then the purchasing power behind that. Most of the managed care is run by contracts. It's not regulation, doesn't take legislation, and can in fact make changes relatively quickly. Again, governors are either unwilling or unable or loath to do that. So we see a lot of control of supply. Finally, Medicaid, of course, not only is a big expenditure for the states, as Sheila said, growing and really putting pressure on traditional state services like education. But Medicaid is something that can be changed, as I said, by contract. And again, the governors don't really exercise the ability that they have to coordinate benefits outside of even the contracts. If you convene governors in a governor's office, the various people who have some role in Medicaid, they often don't talk to each other. Some haven't even met. And so the fact that we have interplay between a health department and a Medicaid, perhaps, department, behavioral health being separate, public health being separate, agriculture, which controls food stamps usually, and in food stamps, nutrition education, as well as nutrition itself. So there is no coordination of the governor's office. The states like to call these silos cylinders of excellence, but they don't happen to turn out that way. So the states have a great role to play. As others have mentioned, they're beginning to experiment, in part because they have to. And it's, again, this can't go on forever. We can't squeeze education forever. without either political backlash or just the impossibility of making all of the ends meet. And so there are great experiments going on. Again, though, I must say, some of them, of course, as Joe has talked about in the paper, and Loren, many of them haven't borne fruit. They are hard to implement, and like many demonstration projects, hard to keep a decent random sample of people you don't treat. And so the states, while being the great experimenters that we'd hoped all along in health and other things, have not produced great changes that have helped guide healthcare. A final factoid, just to give you a sense of how some of this works. California is the lowest per capita expenditure on Medicaid. They pay docs 50% of Medicare, maybe less than that now. But obviously a blue state, and almost a third of their population is on Medicaid, and part of the reason they don't pay as much. But New York, another great blue state, is the highest per capita cost of Medicaid. And so you wonder, how does, in this great expanse, there must be something in the middle that would work for everybody better, at least on Medicaid, and we haven't found it. With that, I will resign to Mr. Reischauer.
Okay, I will start as the others did by thanking AEI, Brookings, and the Concord Coalition for, as I said, keeping the debate going and contributing to it. As is mentioned, I go back a long way with Alice, so I will just say a word about Alice. First paper I ever wrote in 1970 when I came to Washington was with Alice, and we co-authored a number of papers over the years. This is, I believe, the last thing she wrote in the health area. She was well into completing a book on fiscal issues that will be completed by her husband and her children. And so there'll be an offering from Alice, in a sense, on her other big area of expertise, federal budget. This is a very Rivlin-esque paper in the sense that it's balanced, it's moderate, it's well-written, it's clear, and it's generally positive and lays out what seems, I think, to most people to be a pretty reasonable goal. Let's hold health spending to the growth of GDP. I am going to sort of raise some questions on that front. The authors have pointed out that we're trying to reform an extremely complex system, a system that has a mix of public and private financing, has service provision by government, private, and nonprofit entities that vary in size, shape, and organization and respond to different kinds of incentives, that are subjected to regulation at the federal level and at the state level, and that regulation is not always in the direction of higher quality or lower costs. It can be perverted, subverted over time in opposite directions. It's a system that has to operate across a huge geographic expanse where service availability differs, patients' preferences differ, practice patterns differ, input prices differ, institutional availability differs, and serve a mix of people that is extremely variable with respect to income, education, age, health, trust in government, whatever. And it may just be that in this jumbled environment, the goal of holding the growth of spending down to the growth of GDP is unattainable. I just ask you to reflect on the situations in countries which we look to fondly as having achieved the goal that we would like to achieve, and ask, do any of them have a system, an environment, anywhere near as complex and chaotic as we have? And the answer is no, they don't. And that might suggest that if we really are serious about attaining this kind of goal, we just might have to engage in more standardization and uniformity of financing, institutional structure, payment systems, et cetera. I'm not advocating in any way that you have to go all the way to Medicare for all, but I am suggesting that those who are arguing, well, let's have everything you have now plus a public option, are going to bring the growth rate down in any significant kind of way. Now, as Joe has said, the reforms that are recommended in this paper, which I am very sympathetic with, are not new. And among health analysts, they're also not particularly controversial. This strikes me as a consensus package and something that has evolved over the last 10 or 15 years of sort of sensible, incremental steps forward. Shift away from fee-for-service, price transparency, reference pricing, delivery systems reforms like ACOs, bundled payments. You can go on and on, increased competition, increased physician supply, cap the tax exclusion. Okay, we all will vote for it, but one has to ask yourself, if there is this sort of general agreement, and I think there is, why have these reforms not been adopted over the last 20 years? Or when they've been adopted, why have they been subverted one way or the other? And can we expect them in the future to have significant impact, a robust impact that's going to bring the growth rate down? If we leave the system largely as it is, and I think not. And Sheila has pointed out that we have on one side a set of institutions, hospitals, insurers, pharma, PBMs, device manufacturers, whatever, that are, if not overtly and explicitly, at least subvertly, against these. This is their income, as the paper points out, and they, like you and me, will fight against it or try and provide refinements to it that really take the teeth out. And on the other side of the argument, we have the people who pay, the purchasers, the consumers, the employers, and the employees, and they have no real incentive either. Employers are trying to keep employees happy, and employees are happy if you don't change things, and if they don't have to pay too much that they know they're paying. And the huge problem here is that we have inadequate measures of the quality of care that people are getting and inadequate knowledge of how much all of us are taking in reduced compensation to pay for the health care that our employers are providing for us. And until we get around those kinds of things, I think we should set our sights on GDP plus something, and that's not the end of the world. And I just want to end, and I will end because I have a parking meter out there that's gonna, I do respond to economic incentives. But I have a little bugaboo, and that is about GDP and health. I mean, everybody talks about, health is, eating up GDP, consuming GDP, whatever, higher and higher percentage. GDP is the value of goods and services produced by the factors of production resident within the United States over a certain period. So health is part of GDP. If we produce more healthcare spending, GDP goes up, employment goes up. What we should worry about is not the percent of GDP devoted to health, but whether we could get what we get now in the way of health outcomes with fewer resources, with less labor, with less capital, with less raw material inputs. Are we producing health efficiently? And the answer is clearly no, and Loren pointed that out clearly. The feeling is we could devote a lot fewer resources to health and get the same output if we did it efficiently, the way some other countries do. And even if we produced it efficiently, we have to ask ourselves, is that the amount we want or need? And those are very tough questions to answer. I mean, there is no answer to them. They're value judgments, basically. You know, it could be that even if we did it very efficiently, because we subsidize through the tax system and subsidize through other things, health insurance, we're consuming much more efficiently produced health than as a society we should want or need. But you decide those things through the political system, through the values and all of that. And so there's a whole another debate we have to get into once we solve this one, thanks to this paper.
Thank you. Well, those were all terrific comments. I'm a little bit at a loss at where to begin because there's so much to cover here. But I thought I just would jump off a little bit from where Bob just left off and get the group's reaction to where do we go from here. That I think Bob's analysis is correct, that we have this very complex mix of private and public institutions and incentives and regulations and market rules in the United States. Much of what is in Joe and Loren's paper is essentially a prescription to try to get the balance better about where do you need to have some better incentives and where do you need to have better regulations. I think that's the story, frankly, of American healthcare policy for the last 30 years or so, this kind of ongoing tug of war between two sides, some who want a little bit more market, some who want a little bit more regulation, pulling back and forth saying, you know, if we just did it this way or we just did it that way, we'd fix this problem. I'm wondering in the aftermath of the Affordable Care Act's enactment, where we have more insurance enrollment, we have a subsidy structure, even if it isn't always used, that should be covering more of the population. I'm wondering if our political system, let's assume 2020 doesn't happen. We didn't have to have an election next year where they're going to fight about all these things. We could just get 20 to 2021. I mean, is there a way to look at this and say we may be nearing the point where our political system is going to accept Bob's diagnosis, which is, hey, we got this massive, complex system that isn't going anywhere. How do we discipline it better? Is there a better mix of regulation and market incentives that we can keep tweaking, you know, every couple of years? Are we there politically? Or are we still going to have this tug of war where people are reaching for, I don't know, very, you know, sweeping solutions, let's put it that way, that are more ideologically driven than practical? I open that up to any of you to comment on. Somebody.
I think the longer you fail, the greater the chance that we're going to have some overreaction.
Drastic solution.
Drastic solution.
That may not solve it.
Not solution at all. No,
yeah, drastic legislation that doesn't solve it either.
Yeah.
We've historically, I think it's almost every time, we've argued and tried to enact more access to health care, whether it's insurance directly or otherwise. And having failed very often, we turn to expanding Medicaid. We now have over 70 million enrollees in Medicaid and going up. It's the largest health insurance plan, I guess, in the world. And it has a fair amount of standardization in it. There is a minimum benefit defined in federal law. States have and can add more services. So in some sense, we have been creeping toward a bit of what Bob has talked about, federal and state split spending, state administers, all those good things. I'm not advocating that we turn everybody into Medicaid, but many of the solutions that we've been talking about, and some included in this paper, are really more aimed at the commercial sector. Whether it's tax deductibility, even consumer choice. Many Medicaid patients blow through any economic minor incentives that are there, whether it's a deductible or copay and all of that, so they don't have those incentives. Anyway, I will stop by saying we are moving inexorably toward that kind of system, just not with a plan.
I don't know, Jim. I mean, honestly, I think there's going to be one more round of sort of fantasy reform where everything gets fixed and everybody gets in. And then,
You mean legislatively or debating?
Politically.
Debating.
Yeah.
Yeah.
And, well, you know this. I mean, if you look at the people who are not covered, of the 30 million odd uninsured, half of them are eligible for CHIP, Medicaid, or the ACA. Another 5 million or so aren't taking up their employer's offer. Probably 4 or 5 million are here illegally. So you got about 25 million of that 30. You aren't really changing anything if you come up with a Medicare for all. And then you've got some high-income people in the remaining 5 million who presumably just don't want insurance. They're going to self-insure because they have money. And then you've got 2.5, 3 million, I don't know the exact number, who would be in Medicaid if expansion was universal. So I think Dan's point about the next round ending up being a Medicaid expansion is right. I think that's where we end up. And that will be the last of the coverage battles. And
What about on the cost side?
And then the charts all say we're running out of money, and that will force essentially the system we have now where we say we're going to have a big employer subsidy. And now that people who aren't with employers don't get health insurance, let's have a really big ACA subsidy. But wait, they might leave the employer system, so let's make sure we just have competing federal subsidies. And if they all have to get scaled back, then if there's less money, people start to change their behavior. And I think we will do this far more incrementally and far less by design than a lot of these reforms.
As usual, then. In other
As
words,
usual. As usual. I mean,
Right.
I thought actually the ACA was the coverage battle, and that we would do quote healthcare reform every year thereafter for a long time. And I was just wrong about the partisan paralysis that came with it. But that is how we should be doing it. And I just want to emphasize what Dan said, which is the next big healthcare reform is all in the states. The states control the production, the factors of productions, and their competitive playing fields, and all the things that are going to matter. And so that's the most important thing.
But I wouldn't disagree with that, but I also wouldn't ignore the realities Medicare faces. In fact, the ACA did focus on coverage. It did nothing about reform of the system at all. And it achieved some result in terms of coverage by the increase in Medicaid coverage and by the subsidies into the private insurance system. There'll be questions about whether the income issues are right, whether 400% is the right number. I mean, there'll be back and forth if we get beyond the sort of repeal and replace. But I think there are also fundamental questions on Medicare and the structure of Medicare and the issues that have arisen in terms of the complexity of the benefit structure, the A, B, C, D, the out-of-pocket exposure to the elderly, the incentives in the payment system. We know that they are increasingly moving towards managed care. We're at 34%. That number is going up. So I think there will be, irrespective of the outcome of the elections, there will be a renewed focus on Medicare. We haven't really looked at Medicare seriously for some period of time. The changes that came along with the ACA were all about money. It was basically raising the money to pay for the subsidies by essentially hitting at provider rates. But I think the fundamental structure of the Medicare program, what it covers, what it doesn't cover, this question of the role of the private insurers because of the managed care piece of Medicare, but also the complexity of the payment systems, the lack of incentives, I think will come under tremendous scrutiny. Again, irrespective of the outcome of the election, I think Medicare comes back into play.
I think that's true. But I would say in that, this sort of, someone flagged the 30% that's now in Medicare Advantage. I think that's a real opportunity.
Yeah.
I mean, Medicare Advantage has the capacity to be very different in different parts of the country, to match the heterogeneity that Bob emphasized. That's real. It has a crude quality metric that ought to be improved steadily over time, so that stars are awarded for high quality outcomes, and it becomes a pay for performance system, and it's capitated so that you can in fact put some real financial incentives in there. So that's an opportunity, and that's one I think ought to be pursued.
And of course, it's still largely based on fee-for-service.
Yeah.
So, I mean,
Well,
at
it's
the
fine.
end of the day, it is
the
a
moment, yeah.
capitated rate, but it's still based on.
And it's a heavily regulated system, by the
Heavily
way.
regulated
that,
system.
Yeah.
Right.
In some ways, you'd think CMS would rather regulate 200 MA plans rather than 200,000 physicians, right?
Right.
So
It's also not a great benefit. I mean, in some
Right,
ways. I mean,
it's not a great
it's-
benefit.
No, but I mean, the Medicare Advantage is, and
Is,
that's why it's going
correct.
to drive people,
In.
to higher and higher
Right.
Yeah.
participation in Medicare Advantage.
But I must say, the one thing that we successfully avoid talking about is long-term care.
That's our next panel. I'm cognizant of our.
Medicaid.
And Bob's meter is running.
The moderator always has to keep track of these things. I'm cognizant of our time and also Bob's parking issue. So let me just open it up. We're going to have time for, and make it really, really good. We're going to have time for one question. And I saw this gentleman's hand first, so I'm going to go over here. I apologize.
How can there be any
And,
questions left?
That's a lot of
Covered it
pressure.
all.
Hi there, Zach Zaleski from Avalier Health. Thank you all for being here. My question is actually to add another spinning plate to this stage, which is Texas v. U.S., which is currently being deliberated in the Fifth Circuit.
Next question.
I mean, it's a little bit of putting the cart before the horse, but presuming they uphold the Northern District of Texas's decision that the individual mandate is inseverable from the rest of the Affordable Care Act and it goes up to the Supreme Court, how will this throw the whole political question sort of into, I don't want to say chaos, but maybe
That's what it
managed
is
disorder?
right now.
Yeah.
So does anyone have any thoughts on that?
Anyone want to take it on? If not, I can do it, but you guys, you're
No,
first.
there is nobody on Capitol Hill is prepared to deal with that. There is no one in the administration that's prepared to deal with that. And so if you think this is chaos, grab a whiskey bottle and watch.
It's partly why all of the emphasis on things like pre-existing condition.
Yeah.
If ACA gets thrown
Goes
out,
down.
then that goes. So some of the elements that there's much more political agreement on, we think, within the ACA that goes away, we may have an opportunity, or we'll have an opportunity, I think, to reconsider.
Bring us back to reality, Bob. What do you tell us? You want to respond? You want to say anything about that?
No.
No.
A wise man.
That was I'm sorry that we can't have more questions. Our time is up today, but really, we'll bring this group back because they obviously have great experience and a lot of knowledge and depth to what they have to say. So let's join me in thanking them for coming today.